Good evening once again who have joined us for today's session. As a continuation of the NEET PG Rapid Revision series, we'll be starting with the OBG. And for taking the OBG session, we have our faculty of obstetrics and gynecology, Dr. Daffina Blessline, ma'am, a PG resident of CMC Vellore. Thank you for joining us today, ma'am. We'll be having ma'am for 2 days. She'll be revising the previous year questions with us. The session is yours, ma'am.
Good evening. Thanks for the introduction. So let's start with today's session. So we'll go through the past 6 years previously asked questions starting from 2018, the important topics and the relevant theory related to that. So let's start. The first question, in which trimester of pregnancy does acute fatty liver of pregnancy most commonly manifest? So acute fatty liver of pregnancy is a very important liver disorder that happens during pregnancy. It's exclusively something that happens only during pregnancy. Okay, so which trimester does this most commonly manifest? So for that, before that, we'll look at what and all can happen to the liver during pregnancy. What are the different liver disorders that happen during pregnancy? One, as we all know, HELLP syndrome, which is a complication of severe preeclampsia. Next is intrahepatic cholestasis of pregnancy. Next is acute fatty liver of pregnancy and viral hepatitis. These are the different liver disorders that can complicate pregnancy. So of that, the onset in pregnancy, most commonly all liver disorders will exacerbate only during the third trimester. Okay, so HELLP syndrome alone, there's an exception because it's a severe preeclampsia which can manifest in the second trimester also. HELLP syndrome alone can manifest in both second and third trimester. Rest too will manifest in third trimester. Viral hepatitis is variable. It has no trimester differentiation because it can happen anytime during the course of pregnancy. So what are the differentiating features that help you to arrive at the diagnosis? So differentiating features for HELLP syndrome, most commonly there will be a history of elevated BP, either severe preeclampsia or preeclampsia, okay? So there is hypertension and there can be other signs and symptoms of impending eclampsia like headache, vomiting, more commonly epigastric pain, all these can occur. Intrahepatic cholestasis of pregnancy, it's only one characteristic feature which is pruritus. If there is anywhere itching mentioned in your itching, especially of the palms and soles mentioned in your question, you can be very sure that it is intrahepatic cholestasis of pregnancy. Acute fatty liver of pregnancy is a more serious disorder. Okay, so this will more commonly manifest with signs of liver failure. So they can manifest with hypoglycemia and all the other signs of liver failure, okay, including asterixis and constructional apraxia and all that. Viral hepatitis, more commonly, they will have fever. Coming to the enzyme elevation, this is not very specific. High AST levels are seen in viral hepatitis alone. Okay, they have enzyme levels of 2000 plus. Okay, next coming to the elevated bilirubin levels, indirect bilirubin is elevated in HELLP syndrome, whereas direct bilirubin is elevated in intrahepatic cholestasis of pregnancy. The other also it can be elevated, but this hyperbilirubinemia is also non-specific. Next, coming to platelets. Platelets will be normal in intrahepatic cholestasis of pregnancy. Other than that, all the others, there is an increased risk of coagulopathy, increased risk of DIC. So platelets will be deranged. Platelets, PT, everything will be deranged only. Okay. Coming to fibrinogen will be deranged in acute fatty liver of pregnancy, whereas it will be normal in all the other cases. And D-dimer again can be increased in both HELLP syndrome as well as AFLP. One of the complication of HELLP syndrome is DIC. That is why you can have increased D-dimer. Next, PT levels can again be increased in acute fatty liver of pregnancy. Coming to hemolysis, where will you see hemolysis? Again, when there is some abnormal hematological pathology that's happening like DIC. So that's seen in again HELLP syndrome and acute fatty liver of pregnancy. So this is a very important table. This contains all the differentiating features for the liver disorders that complicate pregnancy. Now coming to our question. So which trimester does acute fatty liver of pregnancy most commonly manifest? The answer is third trimester. Okay. Next, coming to the next question. A 55-year-old woman comes with abnormal uterine bleeding. Hysterectomy was done and the following specimen was retrieved. What is the diagnosis? So they can give you a picture-based question like this. This is a cut section of the uterus that is showing a well-circumscribed globular lesion with a whorled appearance. I don't know if you can appreciate the whorled appearance there. So this is characteristically seen in leiomyoma. Okay. So this leiomyoma is the most common benign tumor of the uterus. So it can occur in who are more prone to develop this leiomyoma. They can develop it can occur in nulliparous obese females. Okay. So what is the most common manifestation of leiomyoma? This is a very tricky question. If they ask you the most common manifestation, most commonly they will be asymptomatic. Okay. The most common presentation of leiomyoma is asymptomatic. But if they ask you specifically what is the most common symptom, then the answer should be abnormal uterine bleeding or menorrhagia. Okay. So this is the clinical presentation. So how do you diagnose a leiomyoma? Diagnosis of leiomyoma is based on ultrasound. Okay. Transvaginal or transabdominal ultrasound is the investigation of choice. But one more question is, what is the role of MRI? MRI in leiomyoma will help in fibroid mapping. Okay, there's a term called as fibroid mapping. Before you want to proceed with the surgery, you want to know what is the location and what are the total number of fibroids that are present. Okay, so that is fibroid mapping. So this is the investigation. Treatment will differ depending on the age group of patients. Okay, so when you do a hysterectomy and when you look at the cut specimen of leiomyoma, it's classically well circumscribed, circular, and it has a whorled appearance. So this is all you need to know about leiomyoma. So looking at this picture, the diagnosis should be leiomyoma. Okay. So next, okay, the ligament that maintains anteversion of the uterus during pregnancy is okay. So there are two positions: anteversion, retroversion, anteflexion, and retroflexion. So what is that? Anteversion. Angle of anteversion is the angle between the cervix and the vagina. Okay, between cervix and vagina, you call it as anteversion. So the normal angle of anteversion is 90 degrees. Whereas anteflexion is between the long axis of the uterus and the cervix. Okay. So the angle of anteflexion is 120 degrees. Anteversion is 90 degrees. Anteflexion is 120 degrees. Coming to the ligamentous supports that maintain the position. When coming to anteversion, in case of pregnant females, it is the round ligament that maintains the position of the uterus. Whereas in case of non-pregnant females, it is the round ligament as well as the uterosacral ligament that maintains the anatomical position of the uterus. So in this case, the ligament that maintains anteversion of the uterus during pregnancy is the round ligament. So these are the different supports of the uterus. Supports of the uterus can be divided into primary supports and secondary supports. So what are the primary supports? One is by the muscles that are present. The other is by the ligaments that are present. So what are the different muscles? Pelvic diaphragm, perineal body, and the urogenital diaphragm. When it comes to the ligaments, there are various ligaments that support the uterus. One is the transverse cervical ligament of McIntyre or the cardinal ligament, the uterosacral ligament, the round ligament, pubocervical ligament, and the uterine axis itself. Okay, whereas the secondary supports include the broad ligament, utrovesical fold of peritoneum, and the rectovaginal fold of peritoneum. These are the different supports of the uterus. Of these, the angle of anteversion is maintained by the round ligament in pregnant females and by the round ligament as well as the uterosacral ligament in non-pregnant females. Okay, next coming to quadruple testing. So what is the time period when the quadruple testing is done? Okay, so before we go into that, we should know what is quadruple testing. So what are the four things? Quadruple means four markers are going to be checked. So what are the four markers that we will check in quadruple testing? One is the maternal serum alpha fetoprotein. Next is the beta HCG, unconjugated estriol, and inhibin A. These are the 4 markers that are included in quadruple testing. So when do you do the quadruple testing? Is it done routinely? No. Quadruple testing is not done routinely. It is only done when the female fails to do a screening test, a chromosomal. Only in high risk pregnancies, we generally get to do these chromosomal screening tests, the first trimester screening. So in case of the first trimester screening is not done in the first trimester and they directly present to you in the second trimester, then you can do a quadruple testing. So when is it done? It's ideally performed between 15 to 20 weeks of gestation. Okay, 15 to 20 weeks is the ideal time when you have to do the quadruple testing. So most accurate answer will be between 16 to 18 weeks of gestation. Okay. So these are the different chromosomal anomalies that can be detected with the help of quadruple testing. Trisomy 21, 18, 13, as well as a neural tube defect or an abdominal wall defect. Okay. The only thing you need in by heart the whole table, where it's going to be high and where it's going to be in what condition, which parameters are going to be high. Okay. In trisomy 21, only 2 parameters will be high. One is beta HCG and the other is inhibin A. Remember as A and B, inhibin A and beta HCG. These are the 2 that are going to be high in trisomy 21. So if they give you the options, which of the parameters are high in trisomy 21, it will be beta HCG and inhibin A. All the other parameters will be low in case of Down syndrome. Next, coming to trisomy 18. This is one condition where everything is going to be low. There is no high parameter in trisomy 18 or Edwards syndrome. Next, coming to trisomy 13, which is the Pettau syndrome. Here, inhibin A alone will be high. Okay. And last, neural tube defect or abdominal wall defect, the maternal serum alpha fetoprotein alone will be high. All the others will be normal. This is how you can differentiate between the various chromosomal anomalies. Moving to the next question, what is the ideal number of antenatal visits? Okay, this is a very important question that has been repeated multiple times. So there are two things. One is the WHO criteria. The other is what is our Indian scenario for the number of antenatal visits. Okay, so the WHO criteria will be once every month up to 28 weeks. Okay, so then once every 2 weeks after that, from 28 to 36 weeks. 36 weeks to till term, it should be once every week. So this will account to a total of 12 to 14 visits. Okay. So that is the WHO criteria. Next coming to the Indian criteria. The Indian criteria for the number of antenatal visits should be up to 12 weeks, 14 to 26 weeks, 28 to 34 weeks, and from 36 weeks to term. At least one antenatal visit in each of these time periods is necessary according to the Indian criteria. Okay. So according to the Indian criteria, at least 4 antenatal visits are needed. When do you call a woman as booked? You call them booked if they have at least 3 antenatal visits in a registered center. Okay. So the ideal number of antenatal visits according to the WHO criteria as per this will be 12 to 14. Okay. Next. A woman is diagnosed to be positive for HIV in her first trimester. What is the appropriate management? Option A is to start ART immediately and to continue till 6 weeks after delivery. Option B is to start ART after the first trimester and continue lifelong. Option C is to start ART immediately and continue lifelong. Option D is to start ART after the first trimester and continue till 6 weeks after delivery. So the answer will be to start ART immediately and continue lifelong. That is the NACO guidelines 2021. Okay, the ART guidelines 2021 as given by the NACO is telling that even in pregnant and breastfeeding females, the moment they are going to be diagnosed with HIV, the plan will be to start them on antiretroviral therapy immediately after diagnosis, and that has to continue lifelong. Okay, so what are the drugs that you're going to give? it will be tenofovir plus lamivudin plus dolutegravir. Anytime pregnancy or breastfeeding, this should be your regimen for antiretroviral therapy. Okay, so the dose will be 300 milligram, 300 milligram, and 50 milligram, given as OD dosage. Okay, so the answer will be to start ART immediately and to continue it lifelong. The fate of the Mullerian duct is determined by the X chromosome, Y chromosome, first chromosome, or the second chromosome. To know this, there is a very important table. Okay, there will be a lot of questions that will be asked from that table. So any undifferentiated gamete. Okay, so it's either going to be either going to be 46XY or 46XX. Okay, so this 46XY, there is an SRY gene that is present on the Y chromosome. This SRY gene is going to cause cortical regression and medullary differentiation. That will cause the undifferentiated gonad to develop into the testis. Okay, this testis in turn will have two types of cells. One is the Sertoli cells, the other is the Leydig cells. The Sertoli cells are the ones that are going to produce the anti-Mullerian hormone or the Mullerian inhibiting substance that will inhibit the formation of the Mullerian duct. On the other hand, the Leydig cells are going to lead to the formation of testosterone. This testosterone has three different roles. One, it's going to cause spermatogenesis. Second thing, it's going to promote the formation of Wolffian duct. And third thing, it's going to form dihydrotestosterone. That in turn will lead to the formation of male external genitalia. Okay. On the other hand, in a female where there is no Y chromosome, there is no SRY gene. Okay. When there is no SRY gene, what happens is there is medullary regression and cortical differentiation. That will lead to the formation of that will lead to the differentiation of the undifferentiated gonad into the ovary. Okay, so in an ovary there is no Sertoli cell, there is no Leydig cell, so there's going to be no anti-Mullerian hormone. So the absence of the anti-Mullerian hormone per se is going to lead to the formation of the Mullerian duct. On the other hand, there is no testosterone or dihydrotestosterone. So this is going to cause regression of the Wolffian duct and the formation of female external genitalia. Okay, it's a very simple table. Any undifferentiated any gamete, it's either going to be 46XY or 46XX. Okay, so there is an SRY gene that occurs on the Y chromosome. This SRY gene is either going to cause cortical regression and medullary differentiation that lead to the differentiation of the undifferentiated gonad into the testis. And on the other hand, when there is no SRY gene, there is medullary regression and cortical differentiation that in turn is going to cause formation of the ovary. Okay, so there are two types of cells that will be produced when it is a testis. One is the Sertoli cells, the other is the Leydig cells. The Sertoli cells are going to produce the anti-Mullerian hormone or the Mullerian inhibiting substance. Okay, so this in turn will lead to the inhibition of the Mullerian duct. On the other hand, Leydig cells will produce the hormone testosterone, which is going to promote spermatogenesis, lead to the formation of Wolffian duct. It will get converted to dihydrotestosterone, and that in turn will lead to the formation of male external genitalia. All of these are going to be absent in females. There is no SRY gene. Okay. So this Mullerian duct is so when there is no anti-Mullerian hormone, automatically the Mullerian duct is going to form. That is what is happening here. There is no testosterone, so your Wolffian duct is going to regress and female external genitalia is going to form. Okay, so this is the table. So one more thing is there is an important gene called WNT gene. So like how there is this SRY gene on Y chromosome that leads to male sex development. Similarly, there is a WNT gene on the first chromosome that is going to lead to the female sex development. Okay, so the answer for this will be the fate of the Mullerian duct is determined by the presence or absence of the SRY gene on the Y chromosome. Okay. Okay. So which of the following is the first step after fitting the pessary to check if the pessary is adequately retained? Okay, they are talking about the vaginal pessary that is used in pelvic organ prolapse. So one is asking the patient to void and to see if the pessary is in place. Second thing is to see if the patient feels any discomfort, seeing if the patient feels any discomfort, which means the pessary is retained. Third thing is asking the patient to perform Valsalva maneuver and see if the pessary is in place. Last one will be being able to admit 2 fingers between the ring and the pessary. Okay, the most correct and the best way by which you can assess if the pessary is retained or not that we practically do is you fit the pessary in place and then you perform Valsalva, ask the patient to perform Valsalva maneuver and you check if the pessary is there or is it coming out. Okay, that is the best thing by which you can assess if the pessary is in place or not. Okay, being able to admit 2 fingers is wrong. Being able to admit 1 finger if it's given, then you can accept it. Being able to admit 2 finger is wrong. Okay, feeling any discomfort, asking if the patient to void, all these will be very subjective questions. So that cannot be used to assess if the pessary is retained or not. So when do you call a pessary as well-fitted pessary? It should return to its normal position when the maneuvers like Valsalva maneuvers are stopped. Should be able to slide the ring of the pessary up and down along the vaginal side wall and the edge of the pessary. Should be able to insert 1 finger between the vaginal side wall and the edge of the pessary. When the labia are separated, the pessary should not be visible. The patient should be able to void urine with the pessary in place and should be comfortable. Of these, the best will be to perform Valsalva maneuver and to see if the pessary is in place or not. What are the different types of pessary? The most commonly used pessary is a ring pessary. On the other hand, there are other types like donut pessary, okay, or a gel horn pessary. Okay, all these are the other different types of pessary. Most commonly, we use the ring pessary. So when we come to pelvic organ prolapse, is another important table that you will that will be asked in questions. So the thing is, they'll give you the age group and they will ask you what is the most appropriate surgery that you can do for the patient. If it's a nulliparous patient or if it's a young female, if it's a congenital prolapse, you can tell abdominal sling operations are going to be the best surgical method for correction of the pelvic organ prolapse. So what are the different abdominal sling operations? Either an abdominal wall cervicopexy or a Shirokar sling operation or a Ganna sling operation. Okay, when it is a pregnant female up to 16 weeks of gestation, you can use a ring pessary. Okay, beyond that, you're not going to do any surgical correction or any form of treatment. The only plan will be to do a conservative treatment in the form of pelvic floor exercises in the pregnancy as well as in the postpartum period. Less than 40 years, you can go ahead with a Fothergill's, that is a Manchester's operation or a Shirotkar's procedure. So anytime after 40 years, if the patient has completed the family, then you can go ahead with vaginal hysterectomy with pelvic floor repair. So what is pelvic floor repair? Anterior colporrhaphy and posterior colpoperitoneorrhaphy. Okay, that will be the treatment of choice if it is a more than 40-year female who has completed her family. More than 60 years, if they are unfit for surgery, if they are no longer sexually active, then you can think of colpoclesis. Colpoclesis is nothing. You're going to denude the anterior and posterior vaginal walls and you're going to oppose both the edges. It's basically an obliterative surgery. Another way of classifying the pelvic organ prolapse surgeries will be either a reconstructive surgeries or a obliterative surgery. Of these, colpoclesis is an obliterative surgery. You're basically obliterating the passage through which the prolapse can happen. This is especially done only if they are postmenopausal, sexually inactive females who are unfit for surgery. Okay, if they don't want vaginal hysterectomy and if they want to retain their uterus. Okay. Okay. Next, coming to the next question. A pregnant woman presents with obstructed labor and is grossly dehydrated. Investigations reveal fetal demise. What will be the management? Craniotomy, decapitation, cesarean section, or a forceps extraction? Okay. So once you diagnose a woman to be, when do you diagnose a woman to be in obstructed labor? How will the woman present if the woman is in obstructed labor? She is going to have maternal exhaustion. All these will be mentioned in your question, okay? Dehydration, tachypnea, or tachycardia, okay? Any form of these presentations if you are having, you can diagnose if the woman is in obstructed labor, okay? Once you diagnose a woman to be obstructed labor, okay, before I go to the diagnosis, what will you feel on examination? Okay, when you examine per abdomen examination, you can feel the upper uterine segment is very tense and it is very tonically contracted. Okay, on the other hand, the lower uterine segment is thin and stretched. Okay, so the on per abdomen examination, the upper segment is tense and contracted. The lower segment is thin and stretched. So as a result of which you can feel a ridge between the upper and the lower uterine segment. This is called as the Bandel's ring. Remember, this is felt on per abdomen examination. I'm going to tell you about one other form of ring that you can feel only on per vaginal examination. So this is felt in per abdomen examination, Bandel's ring, okay, or the retraction ring. Okay, so when you diagnose a woman to be in obstructed labor, you can no longer wait. Okay, you should start hydrating her with IV fluids. She's more prone for infection concerning the prolonged duration of labor and everything if we consider. So we should start the patient on antibiotics, and immediate delivery by cesarean section is the only management for obstructed labor. Okay, you can no longer, there is no wait and watch policy. There is no further augmentation with oxytocin once you diagnose the woman to be in obstructed labor. So the three things will be IV fluids, antibiotics, and immediate delivery by cesarean section. So there's one other ring called as the constriction ring or the Schroeder's ring. Okay, there are two types of ring. One is a constriction ring, the other is a retraction ring. The constriction ring is also called as the Schroeder's ring. The retraction ring is also called as the Bandel's ring. So this is because of the incoordinate uterine action. There is no synchrony that's happening between the contractions and retractions. On the other hand, this is because of tonic uterine contractions and retractions. Okay, so the cause will be undue irritability of the uterus due to injudicious use of oxytocin. Without monitoring the contractions, if you are going to keep on increasing the oxytocin, then it's going to cause the constriction ring. On the other hand, retraction ring occurs in obstructed labor. So where do you see the ring? In both cases, it's going to be present at the junction of the upper and lower uterine segment, but constriction ring is fixed. Okay, constriction ring will not change its position. Once a constriction ring is formed, it's going to stay in the same place. Whereas retraction ring or the Bandel's ring, it will start moving upwards because I told you the lower uterine segment is thin and stretched. So as the obstruction progresses, the ring is going to move upper and upper. Okay. So that is one other difference between this constriction and the retraction ring. So as I already told you, Bandel's ring you can feel on per abdomen examination. Whereas constriction ring you can feel only on per vaginal examination. This is one other differentiating feature that you should know. Okay. So the best time to identify the type of twin pregnancy on ultrasound is, okay. So you can identify the type of twin pregnancy on ultrasound ideally when the crown rump length is between 45 to 84 millimeters. When will the crown rump length be between 45 to 84 millimeters? It is between 11 to 13 plus 6 weeks. Okay. So the answer will be 11 to 14 weeks. That is the ideal time when you can identify the twin gestation. Okay. The chorionicity and all that you can differentiate based on the T sign, the twin peak sign, lambda sign. That will help to differentiate between the whether it's DCDA or MCDA. The two signs will help you differentiate between that. So that is seen between 11 to 14 weeks of gestation. Which of the following statements is false about the umbilical cord? It has one artery and two veins. It contains a gelatinous substance called Wharton's jelly. Presence of a single umbilical artery is associated with congenital anomalies, and normal average umbilical cord length is 50 to 60 centimeters. Which of the following statements is false? Okay, first we'll start ruling out. Does it have one artery and two veins? No, it has two arteries and one vein. So that is the answer. Okay, it contains a gelatinous substance called Wharton's jelly. Yes, true. That it contains the Wharton's jelly. Okay, there is a gelatinous mucopolysaccharide that is going to be present, which is called as the Wharton's jelly. Sometimes this Wharton's jelly will start accumulating in localized points. That is when after delivery, when you look at the umbilical cord, you can see some false knots that are present on the umbilical cord. Okay, that is because of the localized accumulation of the Wharton's jelly. Next, the presence of a single umbilical artery is associated with congenital anomalies. Yeah, that is also true. Single umbilical artery is associated with congenital anomalies. Normal average umbilical cord length is 50 to 60 centimeters. Yeah, true. On an average, it's between 40 to 60 centimeters. Okay. Of these, the false statement is it has one artery and two veins. Which of the following statements is false about non-invasive prenatal testing, NIPT? It uses cell-free circulating fetal DNA in the maternal serum. It is used for diagnosis of trisomy 13, 18, and 21. It can be performed after 10 weeks of gestation. It is done after the routine first trimester ultrasound assessment. Which of the following statements is false? It uses cell-free circulating fetal DNA in the maternal serum. Yes, that is the non-invasive prenatal testing. Okay, it is performed after 10 weeks of gestation. True. It is done after the routine first trimester ultrasound assessment. Yeah, after the first trimester ultrasound screening, you are going to do the NIPT. So, which is the false statement? It is used for the diagnosis of trisomy 13, 18, and 21. Is it used for the diagnosis? No. It is a screening. Okay. It is not used for the diagnosis. It is used for the screening of the chromosomal anomaly. So, that will be the answer to this question. Okay. Okay. Which of the following is not a cause for secondary PPH? Retained cotyledon, endometritis, placental polyp, and placenta previa. Okay, so there are two types of PPH. Postpartum hemorrhage, there are two types. One is primary PPH, the other is secondary PPH. The other way of classifying is either atonic or traumatic PPH, but all those are types of primary PPH only. Okay, so primary PPH is anything that occurs within the first 24 hours after delivery. Okay, primary PPH is first 24 hours after delivery. Secondary PPH is when it occurs more than 24 hours after delivery and it is going to continue up to 12 weeks postpartum. Okay, anything between this time duration is what is called as secondary PPH. Okay. So primary PPH is when it occurs within 24 hours. Secondary PPH is when it occurs after 24 hours and up to 12 weeks postpartum. So what are the different types of primary PPH? One, it can be atonic PPH. The second thing, it can be traumatic PPH. Then coagulopathy, any form of DIC or any deranged coagulation or bleeding disorders can lead to primary PPH. Okay. So atonic PPH, as we all know, if there's a problem with the contraction of the uterus, in case of an over-distended uterus, or if it's a placental abnormalities, if there's any placental abnormalities like placenta previa, placenta accreta, placenta increta, if there's a prolonged labor, precipitate labor, if there was a previous history of PPH, all these are going to predispose to atonic PPH. Basically, you needn't remember all this. Anything that's going to hamper with the contraction of the uterus is going to cause atonic PPH. Second thing, if there's any trauma at the time of delivery, any form of perineal tear, any form of laceration, cervical tear, all these can cause traumatic PPH. The third thing is a coagulopathy, any form of DIC or deranged coagulation profile. All these will cause primary PPH. Next, coming to secondary PPH. Secondary PPH is when it occurs after 24 hours and up to 12 weeks postpartum. So what can be the causes? Sometimes after vaginal delivery, if we are not adequately removing the placenta, and if there is some retained bits of cotyledons or membranes in that, that can retain inside, it can lead to puerperal sepsis and further predispose to secondary PPH. That is one reason. Second thing, if there is a uterine inversion that occurs in the immediate puerperal period. Third thing, if there was a fibroid that was complicating pregnancy, that got infected, and that can predispose to a secondary PPH. Endometritis, any form of infection in the decidua, either because of unhealthy decidua or membranes, that can predispose to secondary PPH. Placental polyp, any form of sometimes a placenta can have an accessory cotyledon or an accessory polyp. So when we are removing the placenta, we might not have noticed that polyp. So that will be present inside, and that can cause the bleeding. So last thing, if there are any arteriovenous malformations, AV fistula, all these can cause the secondary PPH. So of these, our question asked what is the which of the following is not a cause for secondary PPH? The answer is retained cotyledon will cause secondary PPH, endometritis will cause secondary PPH, placental polyp will cause secondary PPH. The only answer that is going to cause a primary PPH is any form of placental abnormality, like placenta previa, placenta accreta, placenta percreta, placenta increta, any abruptio placenta, any form of placental abnormality is going to cause a primary PPH. So that is the answer. Okay. A 16-year-old girl with primary amenorrhea has the following features. What is the most probable diagnosis? Okay. There are two important tables that you need to know when it comes to primary amenorrhea if you want to answer the questions. Okay. First, we look at this question. What is the most probable diagnosis? This question, to answer this question, you needn't look at the table and all, because by the clues that you have given, you can actually rule out the options. First thing, normal stature. Thelarchy is absent, which means there is no secondary sexual characters that has developed. Okay. FSH and LH are high, and the karyotype is 46XX. Okay. So based on these features, what can you rule out? The patient is having normal stature. Normal stature will rule out Turner syndrome. Turner syndrome is going to have short stature. Next, FSH and LH are high. What is Kalman syndrome? Kalman syndrome is hypogonadotrophism. So which means FSH and LH will be low. So the Kalman syndrome can also be ruled out. So what are the other two options that are left? One is testicular feminizing syndrome. The other is gonadal dysgenesis. In case of testicular feminizing syndrome, the karyotype will be 46XY. So that also rules out. So the answer will be gonadal dysgenesis in this condition. Okay. But generally, for answering any question on primary amenorrhea, you need to know two tables that are needed. Okay. So the two tables are based on whether secondary sexual characters have developed or not developed. Okay. The first thing is if the patient is having poor or absent secondary sexual characteristics. If the patient is having absent secondary sexual characteristics, the next thing that you have to do is you have to look at the hormone levels. Okay, FSH and LH. If the FSH and LH are going to be low, as we already discussed, that is going to be some form of pituitary or hypothalamic insult that has occurred. That is causing the low FSH and LH. It's not working at the higher levels. You're not even having the stimulus from above that is going to produce your hormones, and that's lead to secondary sexual characteristics development. So where does FSH and LH be low? One is, as we already discussed, Kalman syndrome. Okay. Second thing, if there's any form of hypothalamic pituitary dysfunction. Third thing, if there's any form of intracranial space occupying lesion that is going to compress on your pituitary gland or the hypothalamus. Okay. These are the different causes of low FSH and LH. On the other hand, if the FSH and LH are high, okay, if the FSH and LH are going to be high, then you have to look at the karyotyping of the patient. Okay. Looking at the karyotype of the patient, it can either be 45XO or 46XX. On the other hand, 46XY. If it is 46XY, the only thing that's going to be is it's going to be gonadal agenesis. On the other hand, if it is 45XO, it could be either Turner syndrome. Gonadal agenesis has no specific karyotype. It can occur both in 46XX as well as 46XY type. Okay. On the and one more thing is resistant ovary. Okay, resistant ovary. These are the different types. So when there are poor or absent secondary sexual characteristics, second thing that you have to do is, as we discussed in this table, secondary sexual characteristics were absent. Okay, so if there is a confusion, if you want to, if there is a confusion with the karyotype between testicular feminizing syndrome as well as gonadal dysgenesis, then you can actually look at the secondary sexual characteristics. Secondary sexual characteristics are absent, you can come to a diagnosis of gonadal dysgenesis. Whereas in testicular feminizing syndrome, they will be present. Okay, that is another way by which you can roll out the options. So if there is poor or absent secondary sexual characteristics, you look at the FSH and LH. If the FSH and LH are low, there's some problem that's happening at the hypothalamic and pituitary level that is causing the amenorrhea, primary amenorrhea. On the other hand, if it's high, you're going to take a look at the karyotype. If it is 45XO or 46XX, it could be Turner syndrome, gonadal dysgenesis, or a resistant ovary syndrome. On the other hand, if it is 46XY, it could be gonadal agenesis. This is when secondary sexual characters were absent. What if secondary sexual characters were present? Okay. So if there are normal secondary sexual characteristics, what do you do? If there are normal secondary sexual characteristics, next thing that you have to do is you have to do an ultrasound and look at the uterus. Okay. Ultrasound and look at the uterus. Ultrasound, if uterus is absent and ultrasound, if uterus is present, what are the different things that can occur? If the ultrasound is absent, next thing that you have to do is a karyotyping. Okay, if the uterus is absent on ultrasound, you go ahead with the karyotyping. On karyotyping, if the karyotype is 46XX or 46XY is our question. Okay, 46XY is going to be testicular feminizing syndrome or androgen insensitivity syndrome. On the other hand, 46XX, where there is absent uterus as well as vagina, that is going to be Mayer-Rokitansky-Kuster-Hauser syndrome, which is the MRKH syndrome. Okay, absent uterus, you look at the karyotyping. Karyotyping, if it is XX, it is MRKH. If it is XY, it is testicular feminizing syndrome. Okay. On the other hand, if the uterus was present, okay, there's a normal uterus. Okay, no, there are two. If the uterus is present, you can have two possibilities. One is if it is a normal uterus. The other thing, if there is an enlarged uterus. Uterus is present, but it is enlarged and there is some obstruction in the outflow. Okay, everything that is happening normally, but the menstruation is not happening because there is some outflow obstruction. That is called as your cryptomenorrhea. So you have to look whether there is a imperforate hymen, okay, or if there is some transverse vaginal septum that is present, that is hampering with your menstruation. Okay. On the other hand, if the uterus is normal, then you are going to do all your hormone assays. FSH, LH, prolactin. Okay, you look at the hormone assays and then you have to come to a conclusion. If everything is normal, okay, then it is most probably constitutional or idiopathic. If all the hormone levels are normal, you call it as constitutional or idiopathic. If the LH-FSH ratio is more than 3:1, you call it as polycystic ovarian syndrome, PCOS. Okay. If the FSH alone is high, it could be high in Turner syndrome or a resistant ovary syndrome, or it could be a premature menopause. Okay, but premature menopause is not a cause of primary amenorrhea, but still that is also a reason where FSH can be high. On the other hand, if FSH, LH both are going to be low, as we already discussed, it could be seen in hypothalamic as well as pituitary failure. If the prolactin levels are going to be high, it could be either hyperprolactinemia or prolactinoma that can cause. Then you have to go ahead with other imaging to rule out where the prolactinoma is there and all that. Okay, so this is where secondary sexual characteristics are present. So where secondary sexual characteristics are absent, you directly go to the FSH and LH levels, and depending on that, you come to a conclusion. On the other hand, if there are normal secondary sexual characteristics, you take a look whether ultrasound, whether the uterus and vagina, everything is normal. If the uterus is absent, it could be either MRKH syndrome or testicular feminizing syndrome, which you have to differentiate based on the karyotyping. On the other hand, if the uterus is present, whether it is a normal uterus or abnormal uterus. If it is a normal uterus, you will do the hormone assays. And depending on the hormone assays, you will come to a diagnosis. So these are the different diagnosis that can occur. One is complete androgen insensitivity, Mullerian agenesis or MRKH syndrome, Turner syndrome, complete XY dysgenesis or the Swyer syndrome. The cause for complete androgen insensitivity will be X-linked mutation of the androgen receptor. Mullerian agenesis, there is hypoplastic or absent Mullerian ductal system. Turner syndrome, there is complete or partial absence of one X chromosome, and complete XY dysgenesis, there is SRY gene mutation on the Y chromosome. As we already saw, absent uterus is seen in both testicular feminizing syndrome as well as MRKH syndrome. So absent uterus and upper vagina will be seen. Okay, in MRKH syndrome, ovaries will also be absent along with that. Okay, you are going to differentiate it based on your karyotyping only. Okay, anywhere, any question, if uterus is absent, it's either of these two only, either androgen insensitivity or MRKH syndrome. You have to take a look at the karyotyping and then come to a conclusion. Okay, on the other hand, Turner syndrome and complete XY dysgenesis, the thing will be normal uterus and vagina, but your ovaries are going to be streak ovaries. Again, there also you will do a karyotyping and you're going to come to the diagnosis. In case of Turner syndrome, it either be 45XO or 45X mosaicism. Okay. On the other hand, in case of Swyer syndrome, it's going to be a 46XY. Okay. So this is regarding the different causes of the primary amenorrhea. Okay. Next, coming to the methods of tubal ligation. So this is another important picture-based question that they will ask. Okay. Fimbriectomy is also known as Pomeroy's technique, Uchida's technique, Kroner's technique, or Irving's technique. So the answer is Kroner's technique. Okay. Fimbriectomy is also known as Kroner's technique, which is the most commonly done technique for tubal ligation. It is the Pomeroy's technique. Okay, we will just take a look at what is each of the different techniques. Pomeroy's technique is where you are going to catch hold of the fallopian tube with Babcock's forceps. Okay, you are going to create a loop with the fallopian tube. You're going to tie the base with catgut and you're going to cut the remaining part. Okay, this is what is most commonly performed, Pomeroy. Okay, on the other hand, Irving is where you're going to you cut and ligate the fallopian tube, and one end of the fallopian tube, that is the proximal end, you will bury it in the myometrium, and the distal end you will bury it in the broad ligament. Okay, proximal end will be in the myometrium, distal end will be in the broad ligament. That is the Irving's technique. Okay. The other is Madeliner's technique. Madeliner's technique is similar to Pomeroy's technique only, but the thing is, instead of cutting, you are going to take the crush forceps and you will crush that part of the fallopian tube. Okay, this is more common. This is not commonly used because there are more chances of recanalization and sterilization failure. Okay, and fimbriectomy, as we already discussed, where you're going to cut off the fimbrial end of the fallopian tube. That's called as Kroner's technique. Okay, the other technique is Uchida's technique. Uchida's technique is where you catch hold of the fallopian tube. The muscular layer is alone stripped off from the serosa and removed. And then you cut and ligate it, bury the other end in the broad ligament of the broad ligament. Okay, that is the Uchida's technique. Uchida's technique is also not commonly done. Pomeroy's technique is what is commonly done. And Kroner's technique is the other name for fimbriectomy. Okay, this Uchida's technique and Irving's technique are more or less similar. Only thing, in Uchida's technique, you are going to catch hold of the fallopian tube. You will cut off the muscular layer from the serosa. Okay, and then you are going to bury that end in the broad ligament. Whereas in Irving's technique, there is no muscular layer that is cut off. Directly, you ligate the fallopian tube, bury the proximal end in the myometrium, distal end in the broad ligament. Okay, these are different forms of tubal ligation. Okay. Coming to the next question, which is which of the following cannot cross the placenta? Iron, albumin, IgM, IgG. The general rule is any high molecular weight protein is not going to cross the placenta. Okay. So of these, albumin and IgM are the high molecular weight proteins. One more example is IgA. Okay, all these cannot cross the placenta. So the answer will be 2 and 3. When is dilatation and curettage contraindicated? Dilatation and curettage can be done in cases of ectopic pregnancies. Yes. It can be done in case of menstrual irregularities. Yes, it can be done. Okay. Can it be done in case of endometriosis? Very rarely, but if it's needed, it can be done. What is the contraindication for doing DNC? It's any form of pelvic inflammatory disease. Any form of ascending genital tract infection is where you will not do a DNC. But this is only a relative term that you can use, that it is contraindicated in PID. Of course, it's contraindicated in PID. But if there is a septic abortion that is causing the pyometra and that is leading to the pelvic inflammatory disease, then you have to go ahead with a DNC only. Generally, if there is any form of PID, you don't do a DNC. But if there is some septic abortion that's causing pyometra, then you will have to do a DNC. That's only an exception. Okay. If they ask you any question where DNC is contraindicated, any form of genital tract infection like pelvic inflammatory disease. Okay. A 45-year-old lady complains of postcoital bleeding. She has a positive pap smear. What is the next line of management? So what is pap smear? Pap smear is the screening test that is done for cervical cancer. Okay. Positive pap smear. Next step, are you going to directly go and treat the patient? No, you have to confirm the diagnosis. How do you confirm the diagnosis? You do a colposcopy followed by a biopsy. Okay. So the recent WHO guidelines have said that before the earlier guidelines were saying that the starting age for screening will be 21 years. Then you have to screen every 5 years with a pap smear until the woman is 65 years of age and you get 2 negative pap smears. Okay. The recent modification that is a potential question for your NEET is the WHO has said that you can start the cervical cancer screening at 30 years of age. For a normal female who has no HIV, then you can start the screening at 30 years of age. Okay. And what do? Do you do a pap smear? No, WHO recommends doing a HPV DNA testing as the primary screening test for cervical cancer. Okay. HPV DNA testing, you start at 30 years of age, repeat it every 3 to 5 years till 50 years. Okay. Beyond 50 years, at least 2 smears should be negative. Only if 2 smears are negative, you can stop the screening. But this is entirely different when the woman is having HIV. When the woman is having HIV, you start at 25 years of age and you do HPV DNA testing every 3 years till the woman is 50 years. And beyond that, if there are 2 screenings that have come as negative, you can stop the screening. Okay, so that is instead of pap smear, WHO has said HPV DNA to be the primary screening test to be done. Okay. In this question, if there is a positive pap smear, you have to confirm the diagnosis by a colposcopy directed biopsy. In superfecundation, which of the following is seen? Fertilization of 2 ova released at the same time by sperms released at single intercourse. Fertilization of 2 ova released in the same cycle by sperms released at intercourse on 2 different occasions. Both of the above or none of the above. Okay. Before we go into that, we need to know what is the definition of these 2 terms. Superfecundation and superfetation. Superfecundation is fertilization of 2 ova released in the same cycle by 2 different acts of coitus. Okay. Whereas superfetation is fertilization of 2 ova released in 2 different cycles. Is this possible in humans? Superfecundation. Superfecundation is possible, especially after artificial reproductive techniques. Okay. Is superfetation possible? Fertilization of 2 ova released in 2 different cycles, it's not possible. Superfetation is not possible. Okay, but it is, according to books, it is theoretically possible to 14 to 16 weeks, but it has never occurred in human beings. Okay. The answer for this is fertilization of 2 ova released in the same cycle by sperms released at intercourse on 2 different occasions. That is the answer. All are true about peripartum cardiomyopathy except development of cardiac failure within 5 months of delivery, left ventricular diastolic dysfunction, absence of identifiable cause, and dilated left ventricle. Which do you feel is the answer? The answer for this question will be, what is peripartum cardiomyopathy in the first place? Peripartum cardiomyopathy is an example of dilated cardiomyopathy that is characterized by left ventricular systolic dysfunction. It's not diastolic dysfunction, it's systolic dysfunction. So the answer will be left ventricular diastolic dysfunction. Okay. So before we now move to the next question, we need to know what is the Pearson's criteria for the diagnosis of peripartum cardiomyopathy. Pearson's criteria is the development of cardiac failure in the last month of pregnancy up to 5 months postpartum, 5 months after delivery. Any form of cardiac failure that occurs either in the last month of pregnancy up to 5 months after delivery is peripartum cardiomyopathy. Okay. Second thing, there should be no known cause for this cardiac failure. Okay. And the woman should not have any cardiac disease prior to the last month of pregnancy. Prior to developing this cardiac failure, she should not have any pre-existing cardiac disease. Okay. And the last thing is an echo criteria. Echo criteria is where the ejection fraction is less than 45%. Okay, this is the Pearson's criteria of peripartum cardiomyopathy. So it's a form of dilated cardiomyopathy that manifests as left ventricular systolic dysfunction. This will more commonly begin in the last month of pregnancy till 5 months after delivery. There should be no cause, no cardiac predisposing disease should be there, and echo criteria, ejection fraction should be less than 45%. Okay. One more thing is, recent update is one drug that can be used for the treatment of peripartum cardiomyopathy is bromocriptine. Why bromocriptine can be used is because prolactin is more involved in the pathogenesis of this peripartum cardiomyopathy. At the molecular level, prolactin plays an important role. So immediately after delivery, you can try giving bromocriptine that helps relieving the symptoms and provides a better outcome in case of peripartum cardiomyopathy. Okay. Which of the following is not the mechanism of action of progesterone-only pills? Progesterone-only pills, there are four points regarding the mechanism of action. It thickens the cervical mucus. Yes, it thickens the cervical mucus. Does it prevent ovulation? Yes, it prevents ovulation. Does it kill sperms in the cervical canal? No, it only inhibits their motility. And it inhibits the penetration of the sperm. Okay, so it does not kill sperms in the cervical canal. Which of the following is not considered as a risk factor for a high-risk pregnancy? Obesity is a high-risk pregnancy? Yes. Any form of amniotic fluid disorder like polyhydramnios or oligohydramnios is a high-risk pregnancy? Yes. Anemia is a high-risk pregnancy? Yes. Does previous manual removal of placenta contribute to high risk? No. Previous manual removal of placenta is not a high-risk pregnancy. Any form of medical or obstetric condition that complicates pregnancy, you label it as high-risk pregnancy. But previous manual removal of placenta is not a high-risk pregnancy. Long-standing pelvic inflammation may lead to which of the following condition? This is a very straightforward question. The answer is pyometra. Pyometra is collection of pus in the uterine cavity. Any form of long-standing PID or any other form of lower genital tract infection can lead to pyometra. These are the different stages of PID that you need to know. Stage 1 to 5. Stage 1 is acute salpingitis without peritonitis. There are basically no adhesions. Stage 2 is acute salpingitis with peritonitis, where you can see purulent discharge. Stage 3 is acute salpingitis with superimposed, where the tubes and ovaries are also going to be involved. Okay, that's a superimposed tubal occlusion or tubo-ovarian complex. Stage 4 is a ruptured tubo-ovarian abscess, and stage 5 is a TB salpingitis. These are the different stages of PID. Which of the following is the most common presentation of postpartum nerve injury? Before I come into that, obstetrical, there's something called as obstetrical neuropathies. This refers to any form of nerve injuries that can occur at the time of delivery. Okay, the most common plexus that is involved is the lumbosacral plexus. The most common nerve that is involved is the lateral femoral cutaneous nerve. Okay, so this is going to present as intense neuralgia in the lower limb. You will have cramp-like pain in the lower limb. Okay. The next thing that can occur is peroneal nerve can be involved. So peroneal nerve injury is going to manifest as foot drop. Okay. So the most common thing that occurs is intense neuralgias, but there is no intense neuralgias that is given in the option. The best option that you can select out of these is foot drop. It's definitely not facial palsy, not wrist drop, not claw hand. It should be foot drop only. But the most common thing that occurs is lateral femoral cutaneous nerve of thigh that's going to present as intense neuralgia, which is altered in thyroid profile throughout pregnancy. So this hormone levels during pregnancy is another high area. Okay, which hormones are increased during pregnancy, which is decreased, which remains unaltered during pregnancy. Okay, so free T3 level is going to be normal. Free T4 level is going to be normal. Total T3 level is going to increase. TSH level will initially be increased, but overall it's going to be normal only. First trimester alone, TSH will be increased. Okay. What is causing this T3, T4 level, total T3, T4 level to increase is this alpha subunit of the beta HCG is going to mimic your TSH. Okay, it's going to be similar to your TSH. And that is going to cause increased total T3 and T4. Okay, so that altered throughout pregnancy is total T3 level. So these are the hormonal changes. These are the different hormones and that remain, that alter during pregnancy. Increased will be growth hormone, insulin, prolactin, total T3, T4, aldosterone, testosterone, and cortisol. Decreased will be FSH, LH, and dihydroethyl androstenedione. And unchanged will be free T3, T4, TSH, and antidiuretic hormone. Okay. Which of the following is true about vaginal changes in a normal pregnancy? Vaginal changes in a normal pregnancy, as we all know, acidic pH is going to develop in pregnancy. There's no, the alkaline pH is going to change to the acidic pH in pregnancy. So for it to become the acidic pH, you cannot have decreased number of lactobacilli. Okay. Basically in pregnancy, there is increased vaginal vascularity. And hyperemia, which is your Chadwick sign. These are the vaginal changes that occur during pregnancy. Okay. One is the Chadwick sign. Second thing, there can be increased vaginal proliferation. Okay. Increased glycogen metabolism. Increased number of lactobacilli. So this lactobacilli is going to basically convert all your glycogen into lactic acid. So this is what is responsible for the acidic pH during pregnancy. Okay. And epithelial thinning will also occur. So which of the following, epithelial thinning, epithelial proliferation is going to occur. Which of the following is true about vaginal changes in a normal pregnancy? Is it decreased number of lactobacilli? No, it is increased number of lactobacilli. Is there increased glycogen metabolism in the epithelium? Yes, that is true. Is the pH more than 6.8? No, pH is going to be less than 6.8. It's an acidic pH. Is there epithelial thinning? No, it's epithelial proliferation. So the correct answer will be increased glycogen metabolism in the epithelium. You discover that there is evidence of cardiac malformation in a fetus during a routine ultrasound at 16 weeks. What is the minimum level of fasting blood sugar at which you can suspect overt diabetes? Okay. Any form of congenital malformation. We've already discussed in our class on diabetes. Any form of congenital malformation, is it common in pregerium or tedium? It is common in pregerium because blood glucose levels are going to be increased from day one. So your free radical injury, fetotoxicity is going to happen from day one in pregerium. Okay. So what is the cutoff for diagnosing this pregerium is what they've asked. It's a very straightforward question. So pregerium, as you already know, the cutoff is similar to adult levels only. Fasting blood sugar more than or equal to 126, postprandial blood sugar more than or equal to 200, HbA1c more than or equal to 6.5%. So the answer is fasting blood sugar should be at level of 126 milligrams per deciliter or above for a pregestational diabetes mellitus. A 45-year-old woman presents with a lower abdominal mass and lower abdominal discomfort. On examination, the uterus appears uniformly enlarged and the adnexa is free. MRI shows the presence of a myometrial cyst. Okay, what is the most probable diagnosis? Endometriosis, adenomyosis, leiomyoma, endometrial hyperplasia. What is the answer? This you have to rule out. The one clue that is given here is uterus appears uniformly enlarged, and the MRI shows the presence of a myometrial cyst. The answer is adenomyosis. Okay, but even if you have a doubt in that, you can rule out based on the symptoms also. Endometriosis, what is the most common symptom that's going to happen? Dyspareunia, dyschezia. Okay, all the pain symptoms are going to occur in endometriosis, but they have not mentioned anything about dyspareunia or dysmenorrhea or dyschezia. So that is again going to rule out that. Adenomyosis, yeah, you have a lower abdominal mass, you have a lower abdominal discomfort, uniformly enlarged uterus, free adnexa, MRI showing the presence of a myometrial cyst. All these are going to point to adenomyosis. Is it leiomyoma? They have not mentioned anything regarding any bleeding abnormalities. Both leiomyoma and endometrial hyperplasia, they have not mentioned any AUB component. In leiomyoma, there need not be an AUB component, but still there are no other pointing features that point towards leiomyoma. Endometrial hyperplasia, obviously there's going to be some form of AUB. There's no AUB that's mentioned. Only thing that's mentioned is a lower abdominal mass and lower abdominal discomfort. The answer will be adenomyosis. So what is adenomyosis? Adenomyosis is the proliferation of both endometrial glands and stroma into the myometrium of the uterus. Okay, so implantation of endometrial glands and stroma into the myometrium is called as adenomyosis. So it can be either a diffuse adenomyosis or a focal localized lesion. When it is a focal localized lesion, you call it a adenomyoma. Okay, so what is the clinical picture? The patient might have abnormal uterine bleeding, heavy menstrual bleeding, prolonged bleeding. Okay, the striking feature that is present is there is dysmenorrhea. What dysmenorrhea? Congestive dysmenorrhea. Congestive dysmenorrhea is classical for adenomyosis. It can also occur in endometriosis, but more commonly in adenomyosis. Okay. So which age group of women does this adenomyosis occur in? More than 40 years, multiparous females who have completed their family. This is the age group where adenomyosis is going to happen. Okay. So what is the diagnosis? What is the investigation that you will do? You can do a transvaginal ultrasound. So on transvaginal ultrasound, adenomyosis will have the salt and pepper appearance. The other thing that is going to occur on transvaginal ultrasound is something called as the Venetian blind appearance. Okay, you can see like shadows on transvaginal ultrasound, which is because of the subendometrial striations that are occurring. Okay, so this is on transvaginal ultrasound. You can also do an MRI. MRI will show this myometrial cyst. Okay, but what is the investigation of choice? Investigation of choice will be a histopathological diagnosis only. You cannot do anything preoperatively. After the surgery is done, you can do a histopathological diagnosis to confirm if it is an adenomyosis. Okay. What is the treatment? If they have completed family, if they have severe discomfort, you can go ahead with a hysterectomy. Okay. On the other hand, if they are young females, okay, if they want symptomatic improvement, you can start with NSAIDs. Okay, you can give them mefenamic acid. If it's not responding to the non-hormonal treatment, you can give them hormonal treatment either in the form of progesterone-only pills. Okay, the best hormonal treatment for adenomyosis is going to be Mirena, levonorgestrel intrauterine device. Okay, LNG IUD. Which of the following decreases during pregnancy? This is again a straightforward question only. So for that, you should know the respiratory parameters and their changes during pregnancy. What is increased, what is decreased, and what is unaffected. So increase alone, you can remember with the mnemonic TIM. Okay. Tidal volume, inspiratory capacity, minute oxygen uptake, and minute ventilation. All these are going to be increased. What is decreased? Functional residual capacity, expiratory reserve volume, residual volume, and total lung capacity. What is unaffected? Respiratory rate is unaffected, vital capacity is unaffected, and inspiratory reserve volume is unaffected. So what is our question? Which of the following decreases during pregnancy? The functional residual capacity decreases during pregnancy. Respiratory rate and vital capacity will remain unchanged, and your inspiratory capacity is going to increase during pregnancy. Okay. So this is an important table. You have to remember this table to answer that question. Which of the following is not a contraindication for the induction of labor? Okay, actually there is a list of conditions where labor should not be induced. Okay, but looking at this, you can rule out and also write the answer for this question. In case of a pelvic tumor, Do you go ahead with the induction of labor? No. Pelvic tumor is a contraindication. Herpes infection, active genital herpes is a contraindication. Heart disease. Heart disease is it a contraindication? What is the best mode of delivery in heart disease? Best mode of delivery in heart disease is vaginal delivery, more than a cesarean section. Okay, vaginal delivery with epidural analgesia is the most preferred route of delivery in heart failure. So, is it a contraindication for induction of labor? No. You can go ahead with induction of labor in heart disease. History of lower transverse cesarean section. Previous 3 LSCS. Previous 3 LSCS is a contraindication for induction of labor. Okay, so of these, the answer will be heart disease. So these are the different conditions where heart disease is, where induction of labor is contraindicated. One, if there is a contracted or distorted pelvis, or if there is a CPD. Okay, if there is some form of placental abnormality like placenta previa, vasa previa, any placenta accreta spectrum disorders that are present. Okay, if there is an active genital herpes, if there is a pelvic tumor, CA cervix, transverse lie or footling breach, appreciable macrosomia more than or equal to 4.5 kg, there is severe hydrocephalus, umbilical cord prolapse, any form of fetal distress, previous surgeries, classical C-section, hysterectomy, vesicovaginal fistula, rectovaginal fistula repair, any third degree or fourth degree perineal tears in the previous delivery, more than or equal to three lower transverse cesarean section. Okay, and previous history of uterine rupture. In all these cases, induction of labor is contraindicated, and you have to go ahead with a direct cesarean section. The given image shows what degree of placenta previa. So there are 4 degrees of placenta previa. Okay, stage 1 is marginal. The placenta is upper segment only, but only the lower part of the placenta alone is touching the lower segment, but it is not reaching up to the os. That is stage 1, which is marginal. Okay, stage 2, where it is coming down and it is coming up to the level of internal os, but it is not covering or closing the internal os. It is touching the internal os. Okay, stage 3 is partially closing the internal os, and stage 4 is central or complete placenta previa, where it is going to completely cover the internal os. Okay, these are the 4 stages. So the picture given here is where it is partially covering the internal os. That is stage 3. Central placenta previa is where it is. There might be a confusion if it is stage 3 or 4. Central placenta previa is actually central. It will be correctly in the middle, covering the entire internal os. Whereas in case of the stage 3, it's going to come partially cover the internal os. The rest of the placenta will be lower segment, but it will not come fully down like in stage 4. Okay. There's one more named regimen, one conservative management that is done in placenta previa, which is the Johnson and McAfee regimen. All are normal physiological changes in pregnancy except there are some cardiovascular changes that are normal in pregnancy. Okay, what are the normal physiological changes that can occur in pregnancy? So you can divide them into symptoms, signs, and ECG changes. Okay, what are the symptoms that can occur? Okay, normal physiological signs that can occur. They can have exercise intolerance. They can have dyspnea on exertion. They can have EC fatigability. All these are the normal physiological symptoms that can occur during pregnancy. What are the signs that can occur during pregnancy? Signs and ECG findings. Okay, signs is distended neck veins. Dominant apical impulse. Dependent peripheral edema. Hard sounds. S1 will be loud, wide, prominent split. And they can be a easily heard S3. Okay, these are the different signs that can occur. Coming to the murmurs, that normal murmurs that can occur during pregnancy is ejection systolic murmur up to grade 2/6. Okay, continuous mammary murmur. And soft diastolic murmur But soft diastolic murmur is physiological only in 20%. Okay. Any form of diastolic murmur, if you are getting in pregnancy, you have to evaluate the patient for other cardiovascular diseases. Okay. You cannot take it as physiological. Even though it is physiological in 20%, any form of diastolic murmur in pregnancy will need evaluation. Okay. These are the different signs that can occur. And the other things, as you already know, heart rate, tachycardia can be there. Okay, there can be some prominent basal rails that are present because of the elevation of the diaphragm. These are the main signs that can be physiological in pregnancy. Coming to the ECG changes. What are the ECG changes? The most common ECG change is the left axis deviation by 15 degrees. Why is there a left axis deviation? There is the elevated diaphragm that is pushing the heart upward and outward. That is causing this left axis deviation. 15-degree left axis deviation can occur. There can be a left atrial enlargement. Okay. There can be some form of periods of atrial or ventricular premature contractions. ST changes in inferior leads. Periods of supraventricular tachycardia or ventricular systole. This can also be physiological in pregnancy. Okay, these are the different, this is very important that respiratory system changes and cardiovascular system changes are very important. The normal physiological changes in pregnancy. Okay, so signs will be descendant equines, prominent apical impulse, dependent peripheral edema, loud, wide split S1, easily heard S3, murmurs like ejection systolic murmur up to grade 2/6, continuous mammary murmur. All these are the signs. ECG changes, most common is a left axis deviation. There can also be a left atrial enlargement, atrial or ventricular premature contractions, ST changes in the inferior leads, and periods of supraventricular tachycardia or ventricular systole. Okay. So now coming to our question, all are normal physiological changes in pregnancy except left axis deviation is normal. Yes. Mild ST changes in the inferior leads is normal. Yes. Atrial and ventricular premature contractions are normal. Yes. Pansystolic murmur is it normal? Ejection systolic murmur is normal. Continuous mammary murmur is normal. But pansystolic murmur, you have to evaluate for any valvular lesions. Okay, like some mitral regurgitation or something that can be present. That answer will be pansystolic murmur. Coming to the next question, a pregnant woman with a fibroid uterus develops severe acute pain abdomen at 28 weeks of gestation. There is no history of fever and the WBC count is 8,000 cells per milliliter. The most likely diagnosis is red degeneration of fibroid, preterm labor, torsion of fibroid, none of the above. Okay. There is a pregnant woman, 28 weeks gestation. She is having a fibroid. All of a sudden, she is having acute pain. Okay, any fibroid, if there is acute pain, there are only two differential diagnoses. One is red degeneration of fibroid, the other is torsion. Torsion, when can torsion occur? If it is a subserous pedunculated fibroid. Okay, if this is the uterus, if it is a subserous pedunculated fibroid like this, that can undergo torsion. Okay, so either red degeneration or torsion should be the answer now. How do you differentiate if it's red degeneration or torsion? Red degeneration is an inflammatory state. Whenever red degeneration is there, two things that will happen is fever and leukocytosis. Okay, fever and WBC count is going to be high. But they've classically given you there is no history of fever and the WBC count is 8,000. So the diagnosis should be torsion of fibroid. Why is it not preterm labor? Can preterm labor occur at 28 weeks in a woman with fibroid uterus? It can occur. But they've not mentioned about anything like regular contractions and relaxations, intermittent contractions. They've not mentioned anything about intermittent pain. She's having severe acute pain. Acute pain, you have to look for obstetric emergencies, either a degeneration of fibroid or a torsion of fibroid. So the most likely diagnosis in this case will be torsion of fibroid. What is the first line of treatment of mastitis in a lactating mother? Dicloxacillin, cefazolin, ceftriaxone, or ampicillin? Okay. Before going into that, we'll see what is mastitis. What is mastitis? Mastitis is the infection of breast parenchyma. What is the most common organism that is responsible for mastitis? Staphylococcus aureus. The most common organism is Staphylococcus aureus. Okay. So how do they present? any form of infection, fever, generalized tiredness will be there. Okay, localized breast tenderness, enlargement, swelling, warmth, purulent discharge can be present. Okay, as normal infection features can be present. So what do? You have to do an ultrasound, rule out abscess. Ultrasound is not for the diagnosis of mastitis. You are doing an ultrasound to see if you can continue with the conservative treatment, or you have to go ahead with an incision and drainage. If you have to do an IND or not, that is why you're doing an ultrasound. So you rule out an abscess. If there is no abscess, you take it as mastitis. What is the first line treatment of choice for mastitis? The treatment of choice will be dicloxazoline. Oral dicloxazoline, 500 mg, 4 times a day. Okay. If they are sensitive to penicillin, then you can give erythromycin. Okay. If the staphylococcus is not sensitive to penicillin, if it's a penicillinase producing staphylococcus, then you can think of other options like vancomycin, clindamycin, or cotrimoxazole. Okay, but the treatment of choice is dicloxazoline. Okay, so what is the first line treatment? Dicloxazoline. Major contributor for amniotic fluid post 20 weeks is, okay, this is another important thing that you have to know, the period of gestation and what forms the amniotic fluid. Okay, the period of gestation, first trimester, amniotic fluid is an ultrafiltrate of maternal plasma. Okay, second trimester, less than 20 weeks, extracellular fluid diffusion through fetal skin. Okay, more than 20 weeks, keratinization of the fetal skin will occur. So there is formation of skin barrier. So extracellular fluid can no longer come outside. Okay, so the main source post 20 weeks is going to be fetal urine. Okay, so main contributor post 20 weeks is fetal urine. Okay, so one more question that they can ask in relation to that is the period of gestation and amniotic fluid volume. Okay, around 10 weeks, it's only 10 to 20 ml, 16 weeks, 250 ml, 33 weeks, it's 800 ml, 38 to 39 weeks, it plateaus at 1000 ml, 40 weeks, 800 ml. Even if you don't want to remember all these values, one thing that you have to remember is when the amniotic fluid volume peaks. Okay, it peaks at around 800 to 1000 ml, which is seen at 36 to 37 weeks of gestation. Okay, it peaks at around 36 to 37 and it plateaus at 38 to 39 weeks at 1000 ml. And again, at term it becomes 800 ml. Okay. What will be the level of the anti-Mullerian hormone in low ovarian reserve? In case of low ovarian reserve, the level of anti-Mullerian hormone, the straightforward question, the answer, it's less than 1. What is the normal anti-Mullerian hormone level? 2 to 6.8. Okay. If it is low ovarian reserve, it is less than 1. If it is more than 10, it is seen in two conditions, PCOS and ovarian hyperstimulation syndrome. Okay, these are the conditions where anti-Mullerian hormone is less. Anti-Mullerian hormone has two different roles when it comes to males and females. Okay, as we already discussed, in males, it is going to be formed early in the period of embryogenesis. Okay, during that time itself, anti-Mullerian hormone is formed. This leads to the regression of the Mullerian duct. Whereas in females, it is not formed early in the embryogenesis phase. It is produced only after puberty by the granulosa cells. Okay, anti-Mullerian hormone at puberty, it has two roles. Follicle development, oocyte differentiation. This is not present in embryogenesis. Okay, if it is present in embryogenesis, Mullerian duct itself won't develop. It is formed only after puberty. The maximum dose of PGF2 alpha in postpartum hemorrhage is 0.25 mg, 2 mg, 20 mg, 200 mg. This is a very confusing question. Looking at PGF2 alpha, all of us will go and mark 0.25 mg as the answer. But what's the question? Maximum dose. Why do we use PGF2 alpha in postpartum hemorrhage? It acts on the PGF receptors of the myometrial receptors, and it's going to promote uterine contractility. Okay, the dose of PGF2 alpha is carboprost. That is nothing but carboprost. You're going to give 0.25 mg intramuscularly every 15 to 90 minutes once. Maximum you can repeat is 8 doses. Okay, which is nothing but 2 mg. Maximum number of doses that can be given is 8 doses, which is 2 mg. Okay. What are the contraindications where you are not supposed to give carboprost? Carboprost should not be given in bronchial asthma. And carboprost should not be given when there is suspected pulmonary embolism. Okay. Bronchial asthma and suspected pulmonary embolism are the contraindications. Gestational trophoblastic neoplasm does not include partial mole, choriocarcinoma, placental site trophoblastic tumor, or an invasive mole. Partial mole, is partial mole a gestational trophoblastic neoplasm? It is a gestational trophoblastic disorder. It's a molar pregnancy, hydatiform mole. It's not a neoplasm. Whereas choriocarcinoma, placental site trophoblastic tumor, invasive mole, epithelial site trophoblastic tumor, all these are the 4 GTN. Okay, so the answer will be partial mole. The hormone acting on post-ovulatory endometrium is LH, FSH, progesterone, estrogen. Okay, what are the different phases of menstruation? First phase will be the regenerative phase, which is immediately after the menstruation, where endometrial glands are going to start regenerating. The functional zone is completely lost. Only the basal zone is there. So the glands and stroma in the basal zone will initially start regenerating. Okay, that will lead to the proliferative phase. Proliferative phase is dominated by estrogen. Okay, proliferative phase is dominated by estrogen. The endometrial glands and stroma will proliferate. Okay, they will become enlarged. Okay, the thickness of the endometrium will be around 10 to 12 millimeter in this stage. Okay, this is where ovulation will occur. Okay, so LH surge will happen. I'm telling you in short. Okay, LH surge will happen and ovulation will occur. This is the proliferative phase. Immediately after ovulation, you have the secretory phase. Which is the hormone of the secretory phase? The hormone of the secretory phase is progesterone. Okay, this is the period when there is maximum endometrial thickness. The endometrial glands will become enlarged. They will become tubular, dilated. Okay, you will get something called as the corkscrew or sawtooth appearance of the endometrial glands. Okay, and last thing that occurs is menstruation. There is no estrogen, no progesterone, complete hormone withdrawal. Corpus luteum will form, corpus luteum will regress. There is no estrogen, no progesterone. That is why menstruation is occurring. Okay. So hormone of proliferative phase is estrogen, hormone of secretory phase is progesterone. They have not asked you directly hormone acting on secretory phase. They've only tried to confuse you a little by asking hormone acting on post-ovulatory endometrium. Immediately after ovulation, the phase that comes is secretory phase. Just the hormone of the secretory phase, it is progesterone. Okay. Which of the following is an absolute contraindication to oral contraceptive pills use? This is again a very straightforward question. As we all know, any form of DVT, CVT, any thromboembolism, you are not supposed to give OCPs. So that will be the answer. Thromboembolism. Chronic renal disease, diabetes mellitus, history of amenorrhea are not absolute contraindications. So for that, you need to know the absolute and relative contraindications of OCPs. Absolute contraindication is when there is DVT, stroke, heart disease, severe hypertension, any hepatic adenoma or carcinoma, or if the mother is breastfeeding, if there is a high estrogen state like breast cancer, all these are absolute contraindications. Relative contraindication is when there is cancer cervix or any form of cervical intraepithelial neoplasia, sickle cell anemia, gallbladder disease, diabetes mellitus, benign liver tumors, and history of smoking. All this will be the relative contraindication. So in our case, the absolute contraindication is DVT, okay, thromboembolism. What is the chromosome number of a patient with partial hydatiform mole? 46XX, 46XY, 69XY, 69XXY. Okay. The answer is 69XXY. Partial mole is triploid. So it is 69 always. 69 either XXY or X by Y. Okay, this is a table that is showing the differences between partial and complete mole. Okay, karyotype 69XXY or 69XYY. Complete mole is going to be diploid only. It's similar to normal. So it's 46XX or 46XY. The diagnosis will be either missed abortion. Partial mole will more commonly present like a missed abortion. Okay, you cannot differentiate it from a missed abortion unless you do a ultrasound or a karyotyping. But complete mole, it's like classical molar gestation features where there is hyperemesis, where you can do an ultrasound and show the grape vesicle appearance. All these will be seen at complete mole. So the uterus size will be small for date because this is going to present with bleeding. So even if you examine the uterus per abdomen, it's going to be small for date, whereas this can be large for date. Theca lutein cysts are seen in complete mode. Okay, initial HCG levels will be more than 1 lakh in complete mode. Subsequent gestational trophoblastic neoplasia can occur in complete mode. Embryo, fetal parts, fetal erythrocytes, all these can be present in partial mode. There is focal villus edema in partial mode and widespread villus edema in a complete mode. Okay, trophoblastic proliferation is marked, trophoblastic atypia is marked, everything in complete mode. And there is one cytochemistry that you can do. P57KIP2 staining, which is positive in partial mode and negative in complete mode. These are the differences between partial and complete mode. Main thing that you have to remember are the ones that I've ticked. Okay, theca lutein cyst, subsequent gestational trophoblastic neoplasia, and then where you can feel the fetal parts, where you can get fetal erythrocytes, regarding villus edema, and this immunostaining. Okay, these are the differences between partial and complete mode. What is the dose of ulipristal used in emergency contraception? So emergency contraceptives or postcoital contraceptives, you have to remember this table. This is the different postcoital contraceptives that can be prescribed. So levonorgestrel 0.75 mg stat and another dose after 12 hours. Ethinyl estradiol 50 micrograms plus norgestrel 0.25 mg, 2 tablets stats and 2 tablets after 12 hours. Conjugated estrogen, which is not given in our country, 15 milligram twice daily for 5 days, but we don't use this here. Then ethinyl estradiol 2.5 mg twice daily for 5 days. Copper iode is very rarely used for emergency contraception. Insertion within 5 to 7 days of accidental unprotected exposure. Senchroman 2 tablets twice at an interval of 12 hours within 24 hours of intercourse. This is again not available in our country. Ulipristal 30 mg within 72 hours. Okay, ulipristal, the dose that we give is 30 mg and it should be given within 72 hours of the accidental exposure. So the dose that is answered here is 30 mg. What is the ideal time for NT evaluation? This is again a straightforward question. 11 to 13 plus 6 weeks is the ideal time where you can do the NT scan. What is the abnormal value? More than or equal to 3 millimeters. It increases the risk of trisomy 13, 18, 21. Magnesium sulfate has no role in prevention of seizures and severe preeclampsia, prevention of recurrent seizures in eclampsia, prevention of respiratory distress syndrome in premature baby, and reducing the contractility of uterus. Yes, it prevents seizures. It prevents recurrent seizures in eclampsia. Does it have a role in RDS? No. It only prevents cerebral palsy in the baby. It does not prevent respiratory distress syndrome. Okay. Does it reduce the contractility of uterus? Yes. Magnesium sulfate is also used as a tocolytic. So it reduces the contractility of the uterus also. The answer will be prevention of RDS. Instead of that, if they've given as cerebral palsy, then you can mark it as true statement. Okay. Which of the following is seen in the vertex presentation with complete flexion attitude of head? Complete flexion, vertex presentation, engaging diameter of the fetus will be suboccipito-bregmatic diameter, SOB, okay, which is 9.5 centimeters. So as the flexion decreases from the bregma, it will become the frontal part. You can remember like that, no need to by heart. Complete flexion, it is a suboccipito-bregma. Okay, if there is incomplete flexion, now imagine the baby is not fully flexed, it's only completely, it's only incompletely flexed, and the part that will come in contact is the frontal part. Okay, if there is marked extension, your occiput is going to come. So it's the occipitofrontal. If there is partial extension, which is midway, then you can get the chin, which is the mentovertical. Incomplete extension, again, submento-vertical, and complete extension is where you're going to get the submento-brachmatic. Okay, the most commonly asked is the suboccipito-brachmatic in complete flexion attitude. The engaging diameter will be 9.5 centimeter. A pregnant lady with a history of recurrent abortions is now diagnosed to have antiphospholipid syndrome. What would be the best mode of treatment for her? Aspirin only, aspirin plus heparin, aspirin plus heparin plus steroids, aspirin plus steroids. Okay. What is antiphospholipid syndrome? Antiphospholipid syndrome is a condition where you're going to have recurrent arterial and venous thrombosis. This thrombosis is also going to affect your placental vessels. That will cause uteroplacental insufficiency, as a result of which you're going to have recurrent abortions. Okay, what is the criteria by which you diagnose the antiphospholipid syndrome? Any one unexplained fetal loss, more than 10 weeks of gestation, more than or equal to 3 unexplained first trimester abortions, less than 10 weeks. Okay. Any one fetal death, more than 34 weeks, either due to severe preeclampsia or preeclampsia or eclampsia or any form of uteroplacental insufficiency. Okay, that is going to give the diagnosis of antiphospholipid syndrome. What do you give for antiphospholipid syndrome? First trimester, mother is coming to you with an obstetric score of G4A3. All three are first trimester abortions. First thing that you have to give is you have to order an APLA workup. You have to ask her to come back with an APLA workup. First thing that you need to rule out is whether there is recurrent pregnancy loss or whether there is antiphospholipid syndrome or not. So for that you have to do a APLA workup. What does APLA workup include? Anticardiolipin, lupus anticoagulant, IgM and IgG, beta-2 glycoprotein. Okay, all these are all four are going to be involved in the APLA workup investigation. So any one comes positive, you arrive at a diagnosis of antiphospholipid syndrome. You start the patient on aspirin as well as heparin. There's no point starting the patient only on aspirin or only on heparin. You have to start on both aspirin and heparin. When do you start the patient on steroids also? If it is a secondary antiphospholipid syndrome, if the patient is having any other immunological disorder like SLE, any predisposing factor, secondary antiphospholipid syndrome, you will give steroids. Otherwise, the mainstay of treatment is aspirin and heparin. A 22-year-old pregnant lady presented with a fever and was started on antibiotics. The fever did not subside. On further investigation, she was diagnosed to have septic thrombophlebitis. Okay, which among the following is the next course of treatment for her? This is septic pelvic thrombophlebitis. It's not plain septic. Septic pelvic thrombophlebitis. Which among the following is the next course of treatment for her? So septic pelvic thrombophlebitis is a rare condition. Okay, as a result of pelvic infection, the patient can develop thrombophlebitis that is involving the ovarian veins. Okay, so in this condition, one classical feature is fever will not subside. Whatever antibiotics you're going to give, there's going to be high spiking fever. Okay, diagnosis, the patient will be having a lower abdominal pain. Classically, you will have a sausage-shaped mass in the abdomen, but that sausage-shaped mass is very rare to be seen. More commonly, they will present with lower abdominal pain. So for septic pelvic thrombophlebitis, you have to give both antibiotics and heparin. You don't want it to embolize and cause other complications. So to prevent thrombus formation, you're going to give heparin. So antibiotics plus heparin will be the treatment. What is the treatment of choice for a woman with atrophic vaginitis with complaints of itching? The answer is, do we give steroids? No, use giving steroids to a postmenopausal woman. Do we give antihistamines? Is there any allergic response that is involved in atrophic vaginitis? No. It basically occurs because of vaginal epithelial thinning in postmenopausal women. So what do you give? You can give topical estrogen. Okay. You can give topical estrogen preparations. You can give them some estrogen estradiol cream that can be locally applied that will help with the atrophic vaginitis. Atrophic vaginitis will classically present with what? itching and vaginal dryness. Very rarely they can have dyspareunia and yellow or blood-stained vaginal discharge that can be seen. You give topical estrogen. If it is not responding to topical estrogen, with much precaution, you can give her systemic estrogen preparations. Okay, she's already postmenopausal, elderly age group. It's not advisable, but still, if topical estrogen is not responding, you can think of giving systemic estrogen preparations. The remnants of Wolffian ducts in females are located in. What are the remnants of Wolffian ducts in females called? The remnants of the Mullerian ducts are called as Gartner's duct. Okay. Where are the Gartner's duct located? Leaves of the broad ligament. Sometimes it can retain, it can form a retention cyst. What is that called? Gartner's cyst. Okay. Remnants of Wolffian duct or mesonephric duct in females is called as Gartner's duct. Okay. In which part of the fallopian tube does fertilization occur? So coming to the anatomy of the fallopian tube, what are the different parts of the fallopian tube? One is the interstitial part, which is the shortest part, which is attached to the uterus. Second thing is the isthmus. What is the significance of isthmus? Any form of tubal ligation. Tubectomy is done in the isthmus. Okay, isthmus is a site for tubectomy. What is ampulla? Ampulla is the widest part where fertilization is going to occur. Okay. Next is the infundibulum and the fimbrial part. Okay. So these are the different parts. So what is the question that is asked? In which part of the tube does fertilization occur? Fertilization occurs in the ampulla of the fallopian tube. One extra edge about the histopathology of the fallopian tube. Histopathology, there are three layers. Okay. One is the mesosalpinx, myosalpinx, and endosalpinx. Mesosalpinx is nothing but the serosa. It is the external layer. This muscular layer has a outer longitudinal layer and an inner circular layer. This is the myosalpinx. Myosalpinx has a outer longitudinal, inner circular layer. Endosalpinx is the lumen of the fallopian tube, which is thrown into folds. Okay, so lumen containing different folds are there. Then you will have the basement membrane. Okay, then you will have, what is the epithelium of fallopian tube? Ciliated columnar epithelium. What is one special type of cell that is seen in the endosalpinx of the fallopian tube? Peg cells. Okay, peg cells are nothing but non-ciliated epithelium that is going to help in the capacitation of sperms. Okay, this is a very important question. Peg cells. What is peg cells? Non-ciliated epithelium seen in the endosalpinx of the fallopian tube that is going to help in capacitation of the sperms. Okay. A patient came to the gynecology OPD with complaints of foul-smelling, frothy vaginal discharge and intense itching. On examination, the cervix was spotted and had the appearance of a strawberry. Identify the causative organism. Strawberry cervix is classically seen in Trichomonas vaginalis. They'll give you a picture. Okay, cervix with spotted strawberry-like appearance that is seen in Trichomonas vaginalis. Does Trichomonas vaginalis require treatment of the partner? Yes, it is sexually transmitted, which requires treatment of the partner also. A woman presents to the OPD with complaints of amenorrhea for the past year. She has a history of postpartum hemorrhage and lactational failure. What is the probable diagnosis? Very straightforward question. It cannot be Rotor syndrome. Rotor syndrome is a form of congenital jaundice. It cannot be prolactinoma. It cannot be acromegaly. It is postpartum pituitary necrosis secondary to hemorrhage, which is called as Sheehan's syndrome. What is Sheehan's syndrome? Postpartum pituitary necrosis. Okay, why does it occur? It can occur secondary to a postpartum hemorrhage, hypotension. Okay, that can cause decrease in the blood flow to the pituitary. Generally, immediately after delivery, the pituitary gland will enlarge. Okay, to supply the enlarged pituitary gland, there should be proper blood supply. But if there is any form of postpartum hemorrhage that is causing hypotension and volume loss, that is going to cause decreased perfusion to the enlarged pituitary, that will present as Sheehan's syndrome. What is the classical symptom? Immediately after delivery, they will have lactational failure and Few days after that, they will notice that they have amenorrhea. Okay, other non-specific features like hypotension, tachypnea, tachycardia, all these can be present. Very rarely it can present as an acute emergency. That is called as pituitary apoplexy. Okay, where they will have rapid hypotension, tachypnea, tachycardia, even leading to the death of the mother. Okay, that is a very rare complication where you have to start immediate steroid replacement. That's an emergency, acute emergency condition, pituitary apoplexy. But here it is postpartum pituitary necrosis, which is presenting as lactational failure and amenorrhea. An 18-year-old girl presents with a history of low-grade fever, weight loss, abdominal pain, and amenorrhea for 6 months. On examination, a pelvic mass is felt on the left side, and signs of ascites are positive. What is your diagnosis? Tuberculosis with tubo-ovarian mass, ovarian malignancy, ectopic pregnancy, submucous fibroid. Low-grade fever, weight loss, abdominal pain, amenorrhea. Most commonly, the answer is tuberculosis with tubo-ovarian mass. Okay. This also is more like a diagnosis of exclusion only. Okay, there's no specific criteria by which TB can present. You look at the clinical features, what matches your diagnosis you are telling. Fever can be present in ovarian malignancy. Weight loss can be present. Abdominal pain can be present. Only thing that will not be present is this amenorrhea component. Very rarely malignancies, especially ovarian malignancies, present with menstrual irregularities. Okay. Pelvic mass, signs of ascites, all these can be present in ovarian malignancy also. Okay. But this history of 6 months and this history of amenorrhea points more towards this tuberculosis with tubo-ovarian mass. Very rarely can it be an ectopic pregnancy or a submucous fibroid. It's not going to present. Ectopic pregnancy will not produce any. For amenorrhea, if it's going to be present for 6 months, ectopic pregnancy would have ruptured and presented with hemoperitoneum. Okay, so that is not a diagnosis. Submucous fibroid, you should have some menstrual menorrhagia or any other AUB component, which is not there. Okay. In modern obstetrics, which of the following investigations is used for monitoring the fetus of an Rh negative sensitized mother? What is the investigation to detect Rh isoimmunization? You do a MCA Doppler peak systolic velocity. MCA PSV will be the diagnosis. Any form of Rh isoimmunization, the general algorithm is any Rh negative mother who's coming to your OPD, you do ICT. If it is Rh negative, any form of A negative, B negative, any Rh negative, you do ICT. If the ICT is negative, you needn't worry. If the ICT is positive, you repeat ICT in dilution. Okay, ICT in dilution, what is the critical titer? Critical titer is 1:16. If the titers are touching 1:16, then you have to go to the next step, which is MCA peak systolic velocity. MCA peak systolic velocity more than 1.5 times MOM is the cutoff. Okay, if it is more than 1.5 times the MOM, then you have to go ahead with a fetal blood sampling. You have to do a fetal hematocrit and find out if there is fetal anemia or not. If there is fetal anemia, it might require intrauterine transfusions. Okay, so the diagnosis will be based on the MCA Doppler peak systolic velocity. What is the causative organism for granuloma inguinale? Granuloma inguinale is nothing but the donovenosis. Okay, so what is the causative organism for granuloma inguinale? This Calymatobacterium granulomatis, which is now renamed as Klebsiella granulomatis. Okay, this is a table showing the different forms of genital ulcers that can occur, the incubation period, the causative organism, the clinical presentation, the diagnosis, and the treatment. Okay, incubation period is not commonly asked. More commonly asked is the cause. Genital herpes, it's very evident. It is herpes simplex virus, type 2 more than type 1. It's a syphilitic chancre. Syphilitic chancre is nothing but your hard chancre. It is Treponema pallidum, syphilis. Donovenosis or granuloma inguinale, it is Calymatobacterium granulomatis or Klebsiella granulomatis. Chancroid is nothing but your soft chancre, which is Haemophilus ducreyi. Okay, LGV, it's caused by Chlamydia trachomatis, especially serovars L1, L2, and L3. Okay, so clinical presentation for genital herpes, it's generally a cluster of vesicle-like lesions that is present on an erythematous base. Okay, whereas in case of syphilitic chancre, it will be a single painless ulcer with a clean base and a firm raised border. Donovenosis is a painless papular nodule that erodes into beefy red granulomatous ulcer. All these are the catch points that they'll have in the question. If they have these specific terms, Okay, single painless ulcer, clean base, firm raised border, it is syphilitic chancre. If it's a beefy red granulomatous ulcer, that is donovenosis. Okay, painful. The difference between chancroid and LGV is chancroid, LGV, and this hard chancre is hard chancre and LGV is painless. Whereas chancroid, it is caused by Haemophilus ducreyi. The name has cry. So it is a painful ulcer. Soft chancre is painful. All the others are painless. Okay. Diagnosis for HSV, as we already know, you do a Zank smear. You can find the multinucleated giant cells. Zank cells can be seen. That will help in the diagnosis. Syphilitic chancre and chancroid, both of these are clinical diagnosis only. You look at the lesion, look at the clinical features and diagnose. Donovanosis, you do a biopsy, you can identify the Donovan bodies. And LGV, you have to do nucleic acid amplification test to confirm the diagnosis. Treatment for genital herpes, you give acyclovir, famciclovir or valiciclovir. Syphilis, treatment is either penicillin or ceftriaxone. Donovanosis, you can give azithromycin. Azithromycin either 1 gram once every week or 500 milligram for 3 weeks at a stretch should be given for donovanosis. Chancroid, the treatment is azithromycin or ceftriaxone, and LGB, it is doxycycline. And the most important one that you have to remember is donovanosis or this thing, and syphilis, it is penicillin or ceftriaxone. Which of the following is the causative organism for vulval warts? The causative organism for vulval warts is human papilloma virus, especially types 6 and 11. A 22-year-old pregnant woman at 13 weeks of gestation informs you about accidental exposure to radiation from a chest X-ray at 7 weeks of gestation. What should be the next step advised to her? Continue pregnancy, terminate pregnancy, pre-invasive diagnostic testing, chromosome screening. You will tell her to immediately terminate the pregnancy? No. Chest X-ray, what is the before that you need to know what is the minimum allowed level of radiation exposure that is allowed in pregnancy, especially in the first trimester. You can allow up to 1 millisievert. Okay. From a chest X-ray, how much radiation are you getting? From a chest X-ray, you can get up to less than 0.1 millisievert only. So is that going to cause a significant problem? No. So what should you advise her? You can tell her to continue the pregnancy. Okay. After successful delivery of the baby, the obstetrician witnesses that the episiotomy performed has extended backwards beyond the perineal body. Which among the following is likely to be injured in this case? External anal sphincter, ischiocavernosus, bulbospongiosis, or urethral sphincter. They're basically telling you that episiotomy has extended beyond. It's gone to it's extended beyond and it's reached behind, which is a extension of the perineal tear, which will extend to your external anal sphincter. Okay, what are the different degrees of perineal tear? Degrees of perineal tear. First degree perineal tear is when it involves the skin and superficial mucosa. It basically involves the vaginal epithelium only, without involving the musculature. That is first degree. Second degree perineal tear, when it involves the musculature of the perineal body also. Third degree perineal tear is when it is going to involve the anal sphincters. 3A is when it involves less than 50% of the external anal sphincter. 3B is when it involves more than 50% of the external anal sphincter. And 3C is when it is going to involve both external anal sphincter and the internal anal sphincter. What is fourth degree perineal tear? In addition to the anal sphincters, if your rectal mucosa is also gone, that is fourth degree perineal tear. These are different degrees of perineal tear. A 16-year-old girl presents to the OPD with a history of primary amenorrhea and cyclical pain. Perineal examination reveals a bulge protruding from the vagina. Identify the cause of this presentation. Okay. Classical primary amenorrhea, cyclical abdominal pain. It is cryptomenorrhea. Okay. Diagnosis is cryptomenorrhea. Now we want to know what is the reason for this cryptomenorrhea. They've done an examination which is showing a bulge protruding from the vagina. So which indicates it is imperforate hymen. Okay, the answer will be imperforate hymen. Another cause for this cryptomenorrhea is transverse septum in the proximal vagina. But the thing is, it's not going to protrude as a bluish bulge from the vagina. It will be seen as a transverse membrane. Okay, that is closing the vagina. It will not be seen as a bulge. Okay, so the treatment for imperforate hymen is a cruciate incision on the hymen. That will allow draining of the accumulated menstrual blood. Okay, and thereafter reproductive activities will can be resumed. Okay, so this is regarding cryptomenorrhea. A 24-year-old woman visits the infertility clinic with a complaint of recurrent abortions. Upon investigation, she is found to have a septate uterus. Which of the following corrective procedures has the best obstetric outcome? Jones metroplasty, Strassman's metroplasty, Tompkins metroplasty, and transcervical resection of the septum. Okay, septate uterus, all these are the treatment options. But the question is corrective procedure that has the best obstetric outcome. Best obstetric outcome can be seen only in transcervical resection of the septum, while all the other three are abdominal surgeries. Okay, so when you are going to do these abdominal surgeries, they are going to leave some form of uterine scarring. Okay, this uterine scarring will further lead to infertility. Okay, so the best obstetric outcome is seen only with transcervical resection of septum because it has no uterine scarring. A 60-year-old woman presented with postmenopausal bleeding. Ultrasonography revealed a mass with a feeding vessel as shown in the image below. What is the most likely diagnosis? So there is a mass here. What are the clues that point to the diagnosis? One is she has presented with postmenopausal bleeding. Okay, then there is a feeding vessel. So what is the most likely diagnosis? Single feeding vessel is seen in endometrial polyp. Okay, you can also tell me this localized mass, it's also looking like a fibroid, but the thing is fibroid will not have a single feeding vessel. It will have multiple feeding vessels all around. Okay, so the answer will be endometrial polyp. Fibroid uterus is not the answer. Endometrial carcinoma, there is no other history or no other ultrasound finding that's pointing towards endometrial carcinoma or leiomyosarcoma. The best answer will be endometrial polyp. Endometrial polyp need not present only in postmenopausal females. Normal reproductive age group females can also have an endometrial polyp. So the most commonly will present with either heavy menstrual bleeding, intermenstrual bleeding, your metrorrhagia, or the postcoital bleeding. Okay, so in this case, the woman has presented with postmenopausal bleeding. Next, coming to the next question, a 35-year-old primigravida who conceived after IVF came for an antenatal checkup at 38 weeks of gestation. She was pregnant with DCDA twins. On examination, the first twin was found to be in a breech position and blood pressure was found to be greater than 140/90 on 2 occasions, grade 1 proteinuria. What should be done next? Monitor BP and terminate pregnancy if BP rises. Immediate cesarean section. Terminate pregnancy at 40 weeks of gestation. Induce labor with PG etogen. What should be the answer? What are the clues? She's already 38 weeks of gestation. She's DCDA twins. Okay. Leading twin is in breech position. And she also has 2 high BP readings. Okay. So what do you have to do? First twin, leading twin, non-cephalic. Only way of delivery should be cesarean section. Only if the leading twin is cephalic, you have an option of vaginal delivery. If the leading twin is non-cephalic, straight away you go ahead with the cesarean section. Okay. Why are we not allowing vaginal delivery if the leading twin is non-cephalic? If the leading twin is breech or a transverse lie, it can lead to fetal trapping. Okay, parts may not come out. It can cause trapping of the fetal parts. Second thing that can happen is an umbilical cord prolapse. So to avoid that, you don't allow a vaginal delivery if the leading twin is non-cephalic. Okay, if the leading twin is cephalic, first twin you take out as a vaginal delivery. Immediately after the delivery of the first twin, you look at the presentation of the second twin inside. Okay, if the second twin is breech, what do? You do a assisted breech delivery. Okay, you leave the breech hang on its weight. You do a assisted breech delivery. If the second twin is in transverse lie, okay, you take the patient to OT. Okay, you do an internal podalic version. If it is possible, you will do a breech extraction and deliver the baby. But if it is not possible, you have to do a cesarean section for the second twin. This is how twins are delivered. Second thing that can be asked is what is the mode of delivery? What is the timing of delivery? For DCDA twins, it is 38 weeks. For MCDA twins, it is 34 to 37 plus 6. And for MCMA twins, it is 32 to 34 weeks. Okay. So now our clinical scenario was a 38 weeks mother with DCDA twins, leading to in breech position. Blood pressure was found to be greater than 140/90 on 2 occasions. The second question that should come to your mind is she preeclampsia or not? She's not preeclampsia. Why is she not preeclampsia? She only had grade 1 proteinuria. Okay. According to the ACOG guidelines 2021, if there is grade 2 proteinuria only, you're going to take it as preeclampsia. So she's not preeclampsia, but she's definitely gestational hypertension because you've got 2 BP readings of 140/90. Okay. So if it is like below 37 weeks, then you can actually monitor the BP and you can terminate the pregnancy if BP rises. But in this case, she's already reached 38 weeks. Okay, the timing of delivery is already reached and she's DCDA twins. 38 weeks is the ideal time of delivery. Only thing is the mode of delivery. Mode of delivery, if the leading twin is non-cephalic, it has to be cesarean section. Which of the following efforts of puberty are not mediated by estrogen? Hair growth, cervical mucus secretion, vaginal cornification, and menstruation. The answer is hair growth. Pubarchy is not mediated by estrogen. Okay, so the answer will be hair growth. These are the different actions of estrogen during puberty. Breast development, development of the reproductive tract, menstruation, pubertal growth spurt, vaginal cornification, cervical mucus production, epiphyseal closure, and maintenance of bone formation. A patient is planned to undergo hysteroscopic polypectomy using bipolar cautery. What is the ideal agent for distension? Hysteroscopy using bipolar cautery. What is the ideal agent? You use a isotonic fluid. Example for isotonic fluid in this is normal saline. So you can either use a normal saline or ringer lactate if it is a bipolar cautery. Okay, for example, if they gave the question as a monopolar cautery, you cannot use a isotonic fluid. So what do you do in that case? You either use glycine or mannitol. Okay, glycine or mannitol. A 52-year-old woman diagnosed with carcinoma cervix stage B was advised radiotherapy. Which of the following statements regarding radiotherapy is false? So when you're giving radiotherapy to carcinoma cervix, there is one point where you're supposed to apply the radiotherapy. Okay, so if this is the external os, okay, there's a plane here. So a point 2 centimeter above the external os and 2 centimeter lateral to the external, 2 centimeter lateral to that will be point A. 2 centimeter above and lateral to the external os will be point A, and 2 centimeter above and 5 centimeter lateral to the external os will be point B. This is the plane of application of the radiotherapy. Okay, point A is 2 centimeter above and lateral to the external os. Point B is 2 centimeter above and 5 centimeter lateral to the external os. Okay, so the point A, you apply a radiation of 7,000 centigrade, and point B, you apply a radiation of 8,000 centigrade. What are you covering by point A? Point A is going to involve the parametrial glands. Okay, point A is going to involve the parametrial or the paracervical glands. Okay, so what is the question? Which of the following statements regarding radiotherapy is false? Point B is 3 centimeter lateral to point A. Yeah, if this is 2 centimeter and this is 5 centimeter, obviously B is 3 centimeter lateral to point A. So that is true. Point A is 2 centimeter above to the external os and 5 centimeter lateral to the internal uterine canal. No, it is 2 centimeter above the external os and 2 centimeter lateral to the external os. So this is false. Point A receives a dose of 7,000 centigrade. True. Point B receives a dose of 6,000 centigrade. True. So what is the answer? B is the answer. Identify the findings seen in this hysterosalpingogram. This is a HSG picture that is showing both sides tubes enlarged. So what is that? Bilateral hydrosalpinx. Few image-based questions in this. Identify the maternal condition that can lead to the findings of the baby as shown below. So what is this? This is sacral agenesis or caudal regression syndrome. So where do you see this? You see it in pregestational diabetes mellitus. Okay. So which is the most specific anomaly that you see in pregestational diabetes mellitus? This is your sacral agenesis. Okay, so that should be the answer. Identify the use of the instrument given below. I don't know if you're able to see the edges. So this is your Fallops ring applicator. It basically has two edges like this. Okay, so your Fallops ring applicator. So where do you use this Fallops ring applicator? It is used for tubal ligation. Okay. Okay. So I think that's all for today. Rest of the questions will continue in the next session tomorrow. Thank you.
Ma'am, thank you so much, ma'am. That was a very awesome session. Especially for your session, we are having higher viewership, ma'am, even today.
Okay, thank you.
Okay, we'll see you tomorrow. Friends, please note, tomorrow the session will start at 6 p.m. sharply. Thank you, ma'am. Thank you for the session.
Thanks, Parthiban.